So normally with our normal aging process, so you always kind of think about, well, we have a decline as we age. Well, what is normal and then what is abnormal? And you may be forced with facing that kind of thought process when you're seeing your patient. This person's just, there's something not quite right, but is that just normal because they're 77 years old, or is this something else? And so normal aging, we know that we have decreased, or we have natural atrophy of gray and white matters. There's vascular changes, our glial cells slow down their conductivity. We do have amyloid B deposits. They primarily impact the hippocampus, so short-term memory or recent memories. What did I go into the room for? I forgot my keys. Before I had LASIK surgery, I used to walk around with readers on my head and around my neck, and I couldn't find either of them. So, true story. Or I have pens, one here and one in the ponytail, and where's my pen? They're like, you got two of them on your head. So, but those are normal processes. Blood supply definitely decreases, and just like other vessels in our body, the vessels become sclerosed. They lose their viability with that. Neurochemical changes, we lose receptors. We also lose the production of those neurotransmitters. But we have an increase of phenylalanine oxidase, so MAOI. Now, when we get into the drugs where you guys came in before, a lot of those psychotic drugs are MAOI inhibitors. So if we have an increase in MAO, and then we have an inhibitor on that, that can be okay, but it can also lead to an increase in side effects and depression, and people taking steps to harm themselves. So that's why when you hear all the drug commercials, notify your doctor if you're feeling depressed and so forth, because those are normal changes. But then also vestibular function decreases. So spatial temporal awareness, as well as increased dizziness, lightheadedness, so a lot of different symptoms, and increased fall risk. So we have, the dementia comes in a lot of different flavors. Mild cognitive impairment, mild cognitive, or MCI, is normal aging process. So that's what happens with us normally. Alzheimer's is kind of like, in and of itself, that's plaques, the amyloid B protein plaques that are there. But then we have a lot of different disorders of the frontal and temporal lobes. That can be primary progressive aphasias that basically impacts Broca's area. For some reason, it just goes to the area. PSP, progressive supranuclear palsy, that is also related to Parkinson's disease. We'll talk a little bit about that next time. Lewy body dementia is also Parkinson's dementia, and this is the one where there's, and I should have, I don't know why I didn't think about that on Sunday when I saw the advertisement to throw that in this lecture, but I must be getting home with MCI on that. But Parkinson's, Lewy body typically goes hand in hand with Parkinson's disease. Hallmark is not memory loss, but it's hallucinations and auditory and visual. And then we have a whole bunch of vascular disease processes that also lead to dementia. Basically, it's a lot of ischemia in the brain cells in those areas are dying. Post-stroke dementia is probably the biggest catch-all term that you may hear. So when you are seeing people who are post-stroke, especially with chronic stroke, this is something that you may have to screen for, and because they pretty much will get referred to PT for fall prevention or balance issues, and then you notice that their cognition isn't quite right, and then you're like, well, is this normal aging, or is this as a result of their stroke? And a lot of people will say, well, they've had their stroke and they haven't had a change in status, and we're not gonna improve them because they had their stroke 10 years ago. So, you know, they're not appropriate for PT. Well, I would challenge that they are appropriate for PT because we may be the first ones to screen out post-stroke dementia and then need to establish a plan of care and some baselines and strategies for the person's well-being. Yeah. Structural brain changes in Alzheimer's, grade 3, pretty severe, moderate. When the person gets into this severe stage with the enlarged ventricles and they have significant brain atrophy at that, they're almost in a vegetative type of catatonic state. So it's progressive, it's considered non-reversible. However, you can slow the progression with that. It's pretty prevalent as our population ages. More and more people are going to be impacted by this, whether directly impacted them acquiring the type of dementia or be a caregiver to somebody who has dementia. With that. Prevalence costs a lot of money with that. It's gonna continue to go on, but these are all, you don't need to know these for the test. It's just gives you an idea that it's a big problem. And, but that most people with Alzheimer's are women with that, and that, 3.2 compared to 1.9 women to men ratio with that. The mortality over, these are, I'm looking at the older stats, but over 60, people over 65, 700,000 people will die as a direct relation to Alzheimer's. With it, again, as our longevity increases, disease processes will continue. Lots of impact on caregivers. Caregiving costs a lot of money, especially for persons with Alzheimer's. I was sharing with the other half of the class, my mother-in-law had Alzheimer's and she had some other medical issues, and my father-in-law just couldn't take care of her anymore. The catalyst to seeing, so my husband has 2 other brothers, and I'm the only daughter-in-law, and they, instead of asking the physical therapist with a neurocertified specialist, they asked the chiropractor. Just go figure. And this is when you're like, well, I'm the outlaw, not the in-law, and so you just go, okay, and you're like, I'll be here when you guys figure it out. But we got a call around 2 o'clock in the morning one night, and it was from the police. My mother-in-law had been found on I-80 over by Joliet, 55 in Joliet. Now they live about 2.5 miles from there. At 1 o'clock in the morning in her nightgown with no shoes. It could have turned out really, really bad. Luckily she had a necklace on that I had given her with some medical information. She might wear the bracelet. It was too evident, so she'd always take that off. So medical or bracelet didn't really work, but medical or necklace did. They had taken her to the nursing home that's kind of by their home, and that's how they eventually found that, the name was on the package. She couldn't tell them who she was, or where she lived. She kept telling them she lived in her childhood home, which is, in Joliet, but no longer there. But there was the catalyst of to my husband, like, now do you see Dad can't take care of your mom? Now do you see what I'm talking about? Okay. So sometimes you as a family member, you win the battle, sometimes you don't. It goes to that. But anyway, that was the main thing. So my mother-in-law, we found a Alzheimer's specific nursing home for her, and the cost was, at that time, was over $6,000 a month. So it's very, very expensive. Now, if some people have nursing home insurance, that will pay a portion of that. Medicare pays very little, so it's very expensive here. So a lot of times people are just restricted to caring for this person in their home, because that's what's affordable. And so, but, you know, can you imagine the diligence that you have to take, and it's very wearing on caregivers. So even with respite homes, sometimes you are the therapist for the caregiver, and you may, you know, especially as the disease progresses, you're teaching them transfers, you're teaching them strategies, so for their body mechanics, and stuff, because they're also aging as well, especially if it's a spouse. So know that sometimes you, PT is for the caregiver impact as well. That, a lot of times Alzheimer's, you know, they're not going to disclose to you that I've had because there's that loss of sense of autonomy. So it's very hard for them to admit, like, oh yeah, I haven't been thinking correctly, or because the person kind of knows that it's like, oh, I made that mistake. A friend of mine posted in our Facebook group, she said, look how my mom wrote the date. And she asked me, Mary, do you think this is all dementia? Yeah, do you think it's Alzheimer's? I said, well, I think it's a dementia. I don't know if it's, you know, Alzheimer's. But if her mom wrote the date, like 2018-45, so like 2018, maybe April 5th, but it's January, you know, so it would have been. And the thing is, Karen had said that her mom normally would send a check, because Karen would help pay her bills and stuff, so she was sending Karen a check. And she said, look, this check just wasn't filled out correctly. And that was probably one of the first signs. She's like, do you think I should take her in? I said, well, you need to establish a baseline. So she needs to see the doctor to establish what is the cognitive baseline. It's work that so you can monitor progression. But the etiology of Alzheimer's sometimes is genetic. Definitely we know that these are amyloid B proteins that are deposited and cause plaques within the neural structures of the brain, which is abnormal processing.
Recently there's more research about like amyloid proteins and tau proteins.
So yeah, so tau proteins are the predecessor to the amyloid plaques, and tau proteins can be deposited and they attract more amyloid plaques. Tau proteins are part of the inflammatory process, especially after traumatic brain injury or concussions. So that's why people who have brain injury have early onset of dementia, and or a lot of the depressive, and that's when the suicide rate and everything is increased.
Also last sleep.
Well, it disturbs me. We'll talk a little bit about sleep disturbances in a couple other slides. But yeah, so that it all triggers down the line with that. Also leads to vascular disease. And if your blood's not, you know, going to the brain, nourishing it, then you're going to have some deficits there. So really the only way you can confirm is it Alzheimer's specifically is by a postmortem biopsy, and so they're going to determine it if they have the plaques and the neural fiber tangles. The thing is, we can see that different imaging, that there could be some cortical structure changes. And I would challenge to say that until we find specific drugs that are specific to the different dementias, they're all treated under the same blanket. And, pardon me, so until we can come up with different solutions, a broad scope of dementia is kind of, you know, how it's addressed. Does it really matter to the person if it's labeled A or B? No, they still have a problem. So with that. So normal age-old process is know that we have as normal aging process, those neural fiber tangles are found in the hippocampus, but the cortical structures remain intact, and that's the difference between mild cognitive impairments, where you're having that occasional memories versus Alzheimer's that is a progression. So that's the difference there. So these are clinical manifestations. So here are your sleep disorders, Neil, that you were just talking about. You're like, oh yeah, half sleep, right? Yeah. No, and those are, even in concussion, years later, they may pass from that. But definitely the most, people might notice a personality change first. Also, their inability to learn something new, with that. So going back to if you are, treating somebody with Alzheimer's, and you're thinking back to that motor learning stages, you're back to the very basic stages of motor learning with them, and that's how you should approach and tailor your interventions versus using an autonomous phase with that. Because they're kind of, and they need a lot of procedural memory repetition to do that. But definitely they have sometimes the most common onset is these visual spatial deficits that may occur, and so they can't navigate to the, oh, I got lost going to the grocery store, or something that's very common, and then all of a sudden they're not able to do that. Also, a quick screen for if you're suspecting that as, can they draw a three-dimensional box? So can they, so you're gonna draw it for them. Can they do that? And they often won't. They may only get part of that trick drawn. So they lose that three-dimensional processing of that. Also, the clock tests, because that has some multi-factors, even though it's one-dimensional. But the other thing is, and actually the Glenn Campbell documentary, his wife talks about a lot of times they have hypersexual arousal. So in nursing homes, it is somewhat problematic because people are uninhibited and take advantage of their new libido. So, but yeah, so that's something. It's not uncommon if you're working in that environment for walk in on some activity for that. So the periods of depression, you can usually modify that early on, and then after a while, it can be more agitation and potential for self-harm or violence towards others with that. So medical diagnoses is, where they look at what is the cognitive change. So establishing a baseline is pretty important. And Medicare has put in their guidelines that we should have an annual checkup, and the primary care should be establishing, especially over the age of 65. So anything with Medicare, they're establishing a baseline of cognitive so that they can document any changes with that. What you need, Mike? So what?
Micromotion has a sign-in.
Neuroimaging, and they're going to look at first changes in the brain size. But that the most common is this mid-temporal lobe, is where the most atrophy is typically shown first, and that makes pretty much sense because one of the first signs is sometimes language difficulty. Like that. So stages of Alzheimer's, early to severe. Like that. And this gives you an idea of where it starts in the medial temporal lobe and then eventually spreads all the way through the occipital lobe. So know that progression. Hint, hint, hint. Hint, hint, hint here too. In particular, well, stage 1 is very easy. There's no impairments. But and stage 7 is very severe decline in vegetative state. Needs all help with all. But this is where I would like you to focus between these three, stage 3, stage 4, and stage 5, because that is where you're typically going to be seeing people in the clinic. So pass that along to your colleagues if you want to be generous with your insight for that. But yes, stage 3, 4, and 5, this is where you as clinicians need to differentiate. Okay? Because, so like stage 5, dressing appropriately. This is when you're at the grocery store and it's 90 degrees out and you're in you're in your tank top and shorts and flip flops and the little lady's pushing her cart with two Cokes. Good. Probably has a little bit, it's just not the poor circulation of old age. Two Cokes is the wrong, something going on. But yeah, so know those things. Clinically, you can screen, you can use the mini mental exam, the slums, the MOCA. Slums, you can use what their high school education or less than high school education, a little more discriminative for that. The MOCA has some nice research in between. What is the scoring difference between mild cognitive impairment and what is the score on the MOCA when somebody has a definitive diagnosis through imaging of Alzheimer's? So that is some useful information. You can see that there is about a 6-point difference in those scores. So that is helpful information. The mini mental and the slums have not been validated in that manner. These are the medications for Alzheimer's. The Entrocept, or MLT, is probably the most common drug given. Antihypertensive drugs, just to promote vascular, blood supply, blood flow. Well, I'm of the adage like, well, if you can just get the person moving, maybe that will help too. You don't need to give them an expensive drug with that. And then, as I told the other group, but I think some of you came in at this slide, the Risperdal is typically used for hallucinations. However, be careful with that. You might see different progression of psychosis with that. Again, because remember earlier on the pathogenesis is the increase in the MIOIs. So the uptake, so things that we need to consider in therapy, our job really is to, Garrett.
Yeah. Before, when you were saying that depression was linked to those, were you saying that the depression was linked to the inhibitor or the actual enzyme?
The inhibitor.
The inhibitor.
Because if you're inhibiting it, then so you're inhibiting it, so you get a greater effect. Because this is an inhibitor, and even though we're having an increase when you start, because there's more numbers of those, it has a greater affinity to attach to those in the brain, and then it decreases function. So basically, the uptake of the drug is greater. Okay. And I'm sure a pharmacist would explain it in more technical terms, but that's the easiest thing. And that's what you need to know as a therapist. If you go to pharmacy. Oh, okay. Yeah. Okay. So, therapeutic consideration. We want to just slow these progressions, prevent falls. Again, you're probably that's the most common referral that you're gonna see is somebody with Alzheimer's or dementia in the clinic for is fall prevention or balance training. And you're like, oh my God, how do I even treat balance training? Well, my biggest key or suggestion is make it functional, and then it's the easiest route. Oh, okay. Stretch, right? Know that you want to have a bright environment because some people with Alzheimer's sundown. And you know what I mean by sundowning? No. So when the sun goes down, like towards the evening, they become a lot more restless and increased risk of agitation. So they become combative. So if you can keep a bright environment and bright natural light, it helps them stay on task and prevents the sundowning with that. So movement and exercise. The thing is you want to try to keep them going during the day so that they can actually sleep at night, as we noted before, previous slide, that there is a lot of sleep disturbances. Just like with the brain injury population, that sleep hygiene is important with that. So use visual representation of exercises versus written words, because we know that there's language difficulties with persons with Alzheimer's. So if you can just keep a simple picture, straightforward, hire Lance to draw you some very basic posters. Or, and then there will be help. The other thing is meet them in their reality, whatever their reality is, just meet them there and let them integrate some storytelling into their time. You're gonna, if you're trying to correct them all the time, it's a battle you're not gonna win. So just go to whatever land that they're in and meet them there. Yeah, because at the end, does it really matter if they think they're in Georgia or if they're in Illinois? They're here. So the thing is, make sure when you're exercising with the person, it's easier if you do exercise along with them if it's safer, because you're demonstrating some role modeling and mirroring of that. But if you're asking them to do something painful and they have pain behaviors, are you familiar with pain behaviors? What would you look for? What's a pain behavior? What? Like facial expressing, grimacing, or hesitancy even. Watch for those type of avoidances, because they won't be able to articulate it, but it's probably something painful for them. And that can send them off into an agitated state. So be mindful of that. Appropriate assistive devices. That is always a trick, because you're like, oh, well, they're better with a walker. However, walkers can become weapons. And, and at 4:30 when they sundown, it might take on a whole different thing. So a lot of times you gotta be mindful on what you're prescribing for the person. And a lot of times wandering just is, they're not stay upright, and that's why a lot of nursing homes have, 5-year open spaces and things that they typically don't trip, but they just don't know where they're going, and that's why doors are locked and so forth. Dr. Wojcik and Slider, they did a meta-analysis, or a systematic review is what they did. Implications, their designs appear to be sufficient. Oh, yeah, I would star this slide. There's a question on this. I'm not gonna change that question. But there does not appear to be sufficient compelling evidence for any specific physical activity intervention to achieve a particular outcome for persons with cognitive decline or dementia. That specific PT interventions were not noted, and that their conclusion is that there's more work to be conducted to answer the question, what are the therapeutic effects of activity for persons with cognitive decline? So that was their finding, and then there's been an update, which is there's an 8-page outline in the content folder that we'll go over, talk about. But the other thing is, these are the tips. Nutrition has a lot to do with our brain function in Alzheimer's prevention. So this is a good outline on that. But for prevention, out of Rush University, this MIND diet, which is basically a Mediterranean-based diet, pretty outstanding results. So they followed people following this MIND diet, and if they followed the MIND diet really strictly, they reduced their risk by 53%. 53% with strict adherence. But if they kind of followed it, there was 35% reduction. So it's actually a pretty powerful study to show that our mind does need proper nutrition for optimal functioning here.
Did they discuss the mechanisms of that?
No, that's still under investigation, but a lot of it has to do with the omega-3, the fatty acids. and all of that. So, yeah, so but that's probably the biggest, study that has come out with, like, well, how can we even prevent Alzheimer's is showing through diet and exercise.